أهلا بيكم. Today we'll continue our study of the heart. So let's begin. Um, um, we are still in the middle mediastinum. Last time we discussed the heart. Now it's the great vessels arising from the heart, and the first one is the pulmonary trunk, as you can see here. And remember the embryology, the pulmonary trunk and the ascending aorta were part of the truncus arteriosus, and the septum developed between them. So they are kind of a spiral position around each other. The pulmonary trunk arises from the infundibulum of the right ventricle. Remember the smooth area, outflow, and it has the valve at the beginning and ascends to the left. It was first anterior to the ascending aorta, then at its left side, and under the arch of the aorta it divided into the right and left pulmonary arteries. Okay, this occurs at the level of the left third costal cartilage, T5, T6 levels. The right pulmonary artery is behind the ascending aorta and the superior vena cava, and the left pulmonary artery inferior to the arch and anterior to the descending thoracic aorta. Okay, so this is the pulmonary trunk. Remember the position of the stethoscope to listen to the pulmonary valve in the left second intercostal space. Okay, the ascending thoracic aorta, first it was behind the pulmonary trunk, then it became to the right of the pulmonary trunk, as you can see here, between it and the superior vena cava. And at the level of the plane passing in the angle of Lewis and T4, T5 disc, it continues as the aortic arch that begins at that level and ends at the same level but at the back. Okay. Then it continues as the descending thoracic aorta in the posterior mediastinum. And remember the branches of the ascending thoracic aorta from the sinuses, right coronary sinus and left coronary sinus, to give the right and left coronary arteries. The superior vena cava, it's formed behind the first costal cartilage, descends to the level of the third costal cartilage, where this is the level where it enters the right atrium, and it's at the right side of the ascending thoracic aorta. Of course, you know how it was formed. It was formed by the union of the right brachiocephalic and the left brachiocephalic, and a tributary of the superior vena cava was, yes, exactly, the azygous vein. Vein. Okay. The inferior vena cava comes from the abdomen by the union of the right and left common iliac veins, ascends anterolateral, anterior and to the right of the vertebral column until it enters the diaphragm through the vena caval opening at the level of T8, and right after it enters the thoracic cavity, it empties into the right atrium, and you notice the remnant of the valve that guards the opening in the right atrium, and that valve was to direct blood from the right atrium from coming through the inferior vena cava directly to the left side, because in the fetal circulation the right side had oxygenated, the right atrium actually had oxygenated blood in it, so coming from the mother, so it had to be shifted to the left side through the foramen ovale in the interatrial septum. So these are the great vessels that belong to the middle mediastinum. Why? Because they are enclosed at their ends or beginnings by the pericardium, as you can see here. The lower end of the superior vena cava and the ascending thoracic aorta and the pulmonary trunk included into the pericardium, as we discussed the last time. Okay, now to the cardiac skeleton. You know that the cardiac muscle has origin and insertion. Yes, it originates and inserts into these fibrous rings. It's like a figure 8, 2 rings like a figure 8. Okay, one for the mitral valve, one for the tricuspid valve. The rings, fibrous rings, to provide point of attachment for the cusps, as you can see here, and actually for the cardiac muscle, the muscle of the atria and muscle of the ventricles. And it maintains integrity of the openings it surrounds, and actually act as insulator, insulates the upper heart from the lower heart. There are 2 areas of connective tissue, dense connective tissue actually, connect the aortic ring. This is the aortic ring, I mean, for the mitral valve, for the ascending aorta, with the right and left atrioventricular openings. This is the aortic ring that guards the aortic valve. See this dense area here? This is the left trigone, left fibrous trigone. It has a similar one here, which is the right trigone, that connect the aortic ring with the ring for the actually with both openings for the atrioventricular valves. Okay, so we have the figure 8 openings, and we have the trigones that connect the aortic ring with both. Okay, this is the cardiac skeleton. Now we come to the blood supply of the heart itself, and we said before that blood feeds during diastole. Remember the events that occur at the coronary sinuses, that after the systole, blood returns back and closes the aortic valve, and at the same time enters the right and left coronary sinuses to fill the coronaries with blood. So the heart feeds during diastole. The right coronary artery arises from the right aortic sinus and descends vertical until the inferior margin of the heart, where it gives its right marginal or acute branch. Okay, and turns posteriorly in the sulcus. While it descends, it gives an atrial branch, and gives a branch for the sinoatrial node. So it's very important to know that. Why? Actually, we have what's so-called dominance. Some people have a dominant right coronary, some people have a dominant left coronary. In most people, the dominant is the right coronary because it supplies the SA node. Now, how do you know? By examining the patient, that you suspect a myocardial infarction in a patient. How do you roughly know which coronary is involved, the right or left? By measuring the pulse. If you find a regular pulse with the infarction, this means that it's most probably in the right coronary. Why? Because the right coronary supplies the SA node. Please remember this, and this is a tricky question that you might be asked. Disturbance of the pulse with myocardial infarction indicates that it's most probably the right, but I'm saying most probably because I told you not all people have a right side dominance. Some people have left side dominance. Dominance means it's the one that supplies the SA node with the highest firing rate. Okay, the right marginal branch runs along the inferior border of the heart, and on the diaphragmatic surface, it gives or supplies the AV node before giving its terminal branch, okay, which is the posterior interventricular artery. Posterior interventricular artery in the posterior interventricular sulcus. So it turns around the heart in the sulcus, giving the right marginal here and supplying the SA node at front, AV node at the back, and terminates by becoming the posterior interventricular or posterior descending actually. Okay, this is the right coronary. The left coronary, of course, doctors, of course, you'll find multiple branches. It's not just the branches we just said, but these are the constant branches. Okay, it's logic that the artery, wherever it goes, it supplies the surroundings. Okay, the left coronary artery from the left aortic sinus, between the left auricle and the pulmonary trunk. Here the right was between the right auricle and the ascending aorta. Here between the left auricle and the pulmonary trunk. Enters the coronary sulcus. It gives off the anterior interventricular or the anterior descending, then becomes the circumflex artery that goes in the sulcus with the coronary sinus. Now, observe this. This is the direction of the circumflex, and at the same time, this is the direction of the coronary sinus. So the two blood streams are flowing in the same direction. You're used to the fact that vein is opposite the direction of the artery, but this is one of two areas that blood flows in the vein in the same direction of the artery. You know which one, which is the other side? The portal vein and the hepatic artery. The portal vein and the hepatic artery, blood flows in the same direction. We will talk about that in the abdomen. It gives off the anterior interventricular and the circumflex, as we said. And the anterior interventricular or anterior descending is in the anterior interventricular sulcus, and while it descends, it gives off one or two diagonal branches. How do you differentiate this from the left diagonal or obtuse branch? They are on the surface of the ventricle, not at the border of the ventricle. Okay, the circumflex courses towards the left in the coronary sulcus and gives off the left marginal, the one you see here. Okay, this is the left marginal or obtuse. They call it obtuse because actually we learned this before. The heart has no borders actually. It's just the borders of the shadow. So the one at the left border is the left marginal, which is the obtuse, and the one at the right is the right marginal, which is the acute branch. Now, there are congenital anomalies in the cardiovascular system, especially in those when mothers are used to drinking and drink alcohol during pregnancy. This gives congenital anomalies, especially to the cardiovascular system, or the regular ones we find here, whatever the cause may be, like an atrial septal defect, the foraminal valve didn't close, ventricular septal defect, which the membranous part did not develop, so it has only the muscular part. The membranous part is absent. Pardon. And the Phalus tetralogy. Phalus tetralogy composed of pulmonary stenosis of the pulmonary valve, ventricular septal defect. And remember when I told you before that the ascending aorta and the pulmonary trunk arise at the same site, which is the truncus arteriosus. Sometimes faulty development in which the aorta overrides the septum and opens into the right ventricle as well. So actually blood from the right ventricle enters the ascending aorta, plus ventricular hypertrophy because of the pressure changes in the cardiac chambers. This is the Phalus tetralogy that you will study in internal medicine, cardiology. And also a case with a famous murmur called the machinery murmur with each beat. This is due to the patent ductus arteriosus. Ductus arteriosus that connects the left pulmonary artery or the pulmonary trunk itself to the arch of the aorta, and it closes after birth. So I told you before that there are things that happen at birth. One of the things is closure of the foramen valve, and the second thing is closure of the ductus arteriosus. And by the way, it may stay open for 10 or so days, and it's considered normal, but it eventually closes, and doctors give prescribe indomethacin to close the patent ductus arteriosus. Okay, let's proceed to the veins. The venous drainage of the heart, it must be extensive, so as not for the metabolites not to accumulate in the heart. It's logic. You can't have a cramp in the heart. This is a disaster. So 3 systems actually: the coronary sinus system, the anterior vein of right ventricle, just because it opens independently into the right atrium, so it's considered a system by its own, and the venae cordis minimi, or veins of Thebesius. We'll talk about them now. The coronary sinus receives major tributaries: the great, middle, and small cardiac veins and posterior cardiac veins coming from the ventricle. The great cardiac vein accompanies the anterior descending artery. This is the great cardiac vein, see? And then enters the sulcus, and as it collects tributaries, it enlarges and forms the coronary sinus to continue its course at the back of the heart in the coronary sulcus, as you can see here. Then it opens into the right atrium. See that? This is the coronary sinus. Now, if you remove the coronary sinus, you will find the circumflex branch in the sulcus. So in the sulcus, here at this area, you have the circumflex branch, and you have the coronary sinus on top, on its way to the right atrium. The great cardiac vein ascends in the anterior interventricular sulcus with the anterior interventricular artery. It's not in the anterior interventricular septum, as this is a mistake. In the anterior interventricular sulcus, enters coronary sulcus accompanying the circumflex, and continues to the diaphragmatic surface, gradually enlarging to become the coronary sinus. The middle cardiac vein is the one that accompanies the posterior descending artery in the posterior interventricular sulcus, as you can see here. This is the middle cardiac vein opening into the coronary sinus. The small cardiac vein, the one that used to accompany the right marginal, see? This is the small cardiac vein on its way to the sulcus to open into the coronary sinus. So the small cardiac vein accompanying the right marginal, the great cardiac vein accompanies the anterior descending, the middle cardiac vein accompanies the posterior descending And on the posterior surface of the left ventricle, you have the posterior cardiac vein that opens into the coronary sinus. Okay? There's another vein that used in old books, used to be a system of its own, but it wasn't logic because it also opens into the coronary sinus, called the oblique vein of the left atrium. This one, oblique vein of the left atrium, opens into the coronary sinus. So actually the coronary sinus is the major venous drainage of the heart. There are anterior veins of the right ventricle. You can see the veins here. Why they are a separate system? Because they open individually into the right atrium. They do not open into the coronary sinus, the anterior veins of the right ventricle. And minute veins in the walls of all chambers, the atria and the ventricles, called the venae cordis minimi, and they drain in the corresponding chamber. And if you examine the inside of the chambers carefully, you will find their openings, the minute openings. I think you remember in the last lecture there was a plate where it has the openings of the venae cordis minimi apparent in the plate. Okay. Lymphatics follow the coronary arteries to the brachiocephalic nodes or the tracheobronchial nodes. Okay. The cardiac conduction system of the heart. There's a connected system of special type of cells that are able to fire spontaneously. And if you put two groups of cells together, and one fires in a rate higher than the other, so the one with the higher rate will become the pacemaker. This is the case in the heart. We have first the SA node. The SA node present beside the opening of the superior vena cava, at the top of the interatrial septum. As you can see here, the firing rate reaches 200 firings per minute. Why don't we have a pulse of 200 per minute? We have the normal is 70 or so, 70 or 80, because the continuous control by the autonomic nervous system. So the autonomic nervous system actually either increase the rate of firing or decrease the rate of firing. They cannot increase rate of firing beyond the normal rate of firing of the cells. That's why the cells have high rate of firing, and the autonomic nervous system reduces them to the normal averages. And if you are in an exercise or something and you need a higher heart rate, this is the job of the autonomic nervous system to increase or decrease the heart rate. It's composed of the SA node, as we said. Fibers run through the wall of the atria and converges again to another node besides the opening of the coronary sinus at the base of the interatrial septum, actually at the top of the membranous membranous part of the interventricular septum. It's at the junction. This is the AV node, or the atrioventricular node. The SA node was the sinoatrial node. This is the AV, the atrioventricular node. It has a lower firing rate than the SA node, so the SA node dominates. Now this one gives rise to the bundle of His, or bundle branch, in the membranous part of the interventricular septum, and the bundle branch divides into right bundle branch and left bundle branch. And because the wall of the left ventricle is thicker, is the thickest actually. So the bundle branches has to divide into anterior and posterior branches to cover the whole area, as you can see here. This is the left bundle branch, divides into anterior and posterior branches. This is the right branch, and both descend on the sides of the interventricular septum, as you can see here, and continue in the wall of the ventricle as Purkinje fibers. Purkinje fibers to make sure the spread of the impulse to all the muscles, muscle wall of the heart. The right bundle branch descends till the apex and then turns back, as we studied before, raising the septomarginal trabeculae. Remember the trabeculae carni in the wall of the right ventricle raises the septomarginal trabeculae carni and or the moderator band, and continues as Purkinje fibers as well. From EKG, the old name was ECG, electrocardiogram. You can identify by careful studying of the ECG or EKG which actually, where is the, if any one of the these you can call stations like the SA node, AV node, right and left bundle branch blocks, bundle BBB, bundle branch block. You can know if it's in the right side or it's in the left side. Actually, you can determine if it's in if it was in the left. You can determine in which major branch if you carefully study the EKG. Okay, the place of the Purkinje fibers is the subendocardial subendocardial plexus of conduction cells. The last thing to say about the nerve supply of the heart, it has autonomic supply, of course. It's involuntary. It regulates the heart rate and force of contraction and cardiac output. Force of contraction and cardiac output per minute, okay? The parasympathetic and sympathetic branches form the superficial cardiac plexus. It's inferior in the aortic arch, inferior to the aortic arch. Remember the cardiac branches we studied in the neck, descending from the sympathetic chain. This is their destiny, actually destination, I mean, to the superficial cardiac plexus inferior to the aortic arch, and deep cardiac plexus between the arch and the tracheal bifurcation, and they all send branches to the heart to supply. The parasympathetic, what does it do? It decreases the heart rate, like what happens during sleep. Sleep is parasympathetic is dominant, so it decreases the heart rate, reduces force of contraction, and constrict coronaries. Mean in the relaxed state. It's not in the exercise state, for example, in the relaxed state. The sympathetic, on the other hand, from the cardiac nerves of the sympathetic trunk, we studied in the neck, preganglionic fibers from the upper 4 or 5 spinal cord segments, synapse. Remember, they were coming from the upper and middle cervical sympathetic ganglia and upper thoracic ganglia as well. And stimulation causes increase in the heart rate, increase in the force of contraction, and dilates coronaries. So it's like what happens in fear, in exercise, in anger, and all these hyper states of the body, of the nervous system, I mean. Sensations coming from the heart carried by both sympathetic and parasympathetic, but there is a difference. Sympathetic carries the pain sensations from the heart, so you expect the pain to be referred to the dermatomes that has the same root value of the afferents that came to the CNS, to the spinal cord, okay? And those from the vagi or two vagi the sensations going through the vagi, they carry information about the blood pressure in the chambers and the blood chemistry, the tension of CO2 and O2 in the blood. Okay, this concludes the middle mediastinum, the heart and the middle mediastinum, and next time we'll be discussing the posterior and superior mediastina. I hope this lecture was of maximum benefit to you, and thank you very much for watching.